Wonderful. Good afternoon, everyone, and welcome to our first roundtable of the German-Israeli Health Forum for Artificial Intelligence, short GIHF-AI, in 2023. For those who are for the very first time, my name is Carsten. I'm the Executive Director of the European Leadership Network in Germany. And on the behalf of all our colleagues in Germany and Israel, it's my pleasure to welcome all of you from both countries, and if I'm not mistaken, also from third-party countries who joined us today to discuss with us on the latest technological issues on standards of medical data, on FHIR, fast healthcare interoperability standards for healthcare organizations. As I just mentioned, this is the first roundtable, so we are basically restarting a new year. We're looking back to an amazing first annual conference that took place in November last year with Israel's health minister Nitzan Horowitz, with Esti Shelley and Dr. Susanna Otzegowski from both ministries of health from Israel and Germany, and many experts from academia, from the medical sector who joined us to discuss, to find mutual solutions, to exchange best practices. And for those of you who want to review what we discussed during our last annual conference in Tel Aviv in November, please have a look at our website. We will put the direct link to the report of the conference, including some political recommendations for both countries in the chat. Maybe someone of our team may be so kind, and please have a look there. And also, for those of you who are not registered yet to our regular email newsletter, which is published in English, please feel free to do so and share the good news also on your social media channels, no matter if it's LinkedIn, where we do have our own account, or on any other social media channel. As I already mentioned, today we will focus on one of our three pillars of the program, which is technology and security. And after discussing interoperability in general last year, we will deep dive into the question of how to implement the HL7 standard FHIR in healthcare organizations. I'm very delighted that for this purpose, we have two amazing experts with us today. We have Professor Dr. Sylvia Thun from the GIHF at the Charité, and we have Dr. Lerner from Maccabi Healthcare Services. So again, for this bilateral program, a speaker from Germany and a speaker from Israel. Being a kind guest here in Germany, usually it would be ladies first, but here we will start today with our Israeli guest, as he made all the efforts to join us here in Zoomland, Dr. Lerner, who will give us a short intro, about 15 up to 20 minutes, about the experiences at Maccabi Healthcare Systems. And you probably all have seen also the latest paper that is published on our website. He contributed, so thank you very much, Uri, for your deep dive, for the contribution. We just discussed that you will give us an even more recent update now that could not be in the paper yet. And your keynote will be followed then by Professor Dr. Thun, who will give us insights as a member also of the GIHF-AI Board of Trustees about her work and her experiences at the Berlin Institute of Health at the Charité. So without further ado, Uri, the floor is yours.
Thank you very much for having me and for this opportunity. And I'll share my screen 1 second and I'll make sure it works fine. And if everybody can see my presentation, then I'll begin. And just someone can say everything's okay?
Yes, everything's okay.
Thank you. So the title, as I named it, also in the paper that was present, it's Rough Waters to Smooth Sailing. And why am I calling it like this? Because hopefully by the end of the presentation, you will see that going into FHIR in a medical organization that wasn't aware of what is FHIR beforehand is not an easy task. It is very important, and as we'll discuss further downstream with in the workshop itself, but it takes lots of thinking and lots of efforts to do it correctly. So first, for the non-Israeli audience, we'll talk about a little bit about what is Maccabi and what do we consider our FHIR strategic plan or FHIR roadmap and what it includes. And then we'll deep dive into the first use case, which I chose to present today, which is the medical diagnosis and what are the different data sources and a little bit about the fire modeling. I won't go into too many technical details because I know the participants are varied between clinicians and more from the IT field, but I'll try to touch every topic in short, and then we can talk about it later during the workshop itself. So first, a little bit about Maccabi or MHS, Maccabi Healthcare Services. Maccabi in Israel, we have 4 Kupot Cholim, HMOs, health maintenance organizations. Maccabi is the second largest one with over 2.5 million members and over 6,000 physicians, not to mention very other medical professions. If looking at our data, we have over 20 years of patient data, most of it logged electronically, both for clinical and demographic details about our patients. And we have roughly 22 million encounters every year, all logged into the same system. And as I was talking about it, I'm talking about a unified EMR, or I know that in Germany you call it an EPA. All medical functions within Maccabi use the same EMR, we call it clicks, and it also receives data from external sources, which I'll elaborate a bit later on when talking about diagnosis. So we're talking first and foremost about the medical data, and it's lots and lots of data, and how do we look at it? And of course, everybody knows data is the base for every artificial intelligence or every use that you want to make with it. So what is Maccabi's vision talking about FHIR? First thing, we want to map all the components of our database of the medical record, and it doesn't matter where they come from, who's in charge, who's managing them. We need to understand it business-wise. What are we talking about? Then we need to go and deep dive into the technical aspect. We have all those sources. It's in the organization, they're coming from outside. We need to understand the data itself. What are the differences? What are the common areas? And how do we approach them? After we've done mapping, the next step, of course, is to use FHIR itself. We need to represent our entire data structure as FHIR resources. And why do I have the small adapted or asterisk here? We call it Mac file. As I'll elaborate later, not always it's so easy to go full FHIR. Maybe we need to make some compromises, but these compromises are only internal within Maccabi. And when we will decide to broadcast FHIR data outside, interoperability to other organizations, it will be full on FHIR, exactly as the model itself defines, but with it, we have some little adjustments. So it's FHIR with a small dot next to it. Eventually, what we do want, what is the final result, the end goal of this entire huge endeavor, is we want to have the entire medical record very flexible and very capable to do any interoperable project that we think about. And even those that we don't think about yet, and some other member company organization, someone from the academy will come and say, here, I want to do this. We need our data structure to support it. And this is why we invest so much efforts into FHIR. So how do we decide to do it a little bit more in details? First, to do some projects. We want to go into small scale, time-limited projects, one step at a time, to learn FHIR, to have our teams understand what is FHIR, to have our managers, the entire infrastructure of the organization, understand both the benefits of FHIR, but also what are the challenges. And when we understand FHIR, this is the time to go to the heavy cannons and to go to a new representation of our entire medical record in FHIR, which is a huge project. It will take us several years at most, but we need to start it. And when I'm talking about projects, so we had a wound assessment project, which was an interface to an Israeli startup company that has an app that takes a picture of a wound and gives characteristics, size, color, kind of tissue. And this data is broadcasted to Maccabi's EMR as a FHIR resource. We're going into a project of digital prescriptions coming from hospitals to Maccabi, also in FHIR. Continuity of care between hospitals. If the patient is being discharged from a hospital after surgery and comes into Maccabi, the entire data, the recommendations, the physical therapy assessment, everything will be broadcasted as FHIR resource to Maccabi. But these are small projects. When we're talking about the big time medical record representation, we're talking about diagnosis. We're talking about the entire documentation of allergies. We're talking about referrals and medical encounters. And bit by bit, our entire medical record. So let's go into our use case. which is, I think most of the people came to hear about more specific details. So we're talking about medical diagnosis. And when we started, as I mentioned, to think about a problem from the business aspect before diving into the technical aspects. The first source of diagnosis, of course, is our EMR. But even within our EMR, there are two different types of diagnosis. We have the ones that are logged during a medical encounter. The patient comes to his physician with a headache and get a diagnosis of a headache. But it's a one-time, maybe it will repeat or recur sometime, but it's not something continuous. On the other hand, he has medical diagnoses, which are, let's say, medical background. He has diabetes or he has asthma. He gets a diagnosis which stays there for good. Maybe it will be stopped if it's a condition that heals, but it might stay from encounter to encounter. And then we didn't talk about the data yet, but maybe we need to address this difference when we think about how to convert it to FHIR. A second source, also internal within Maccabi's system, is more of the financial side or claims authorization, because when a patient needs to receive a very expensive medicine, Maccabi can decide, I will grant it to him only if he has a certain medical diagnosis that entitles him to be eligible for that medication. And that when this approval is saved, it also documents the diagnosis for which the approval was given. So also it's a source of diagnosis within our system, although they are not logged in from the EMR itself. A third source of diagnosis is completely external. It comes from hospitals. When a patient is discharged from a hospital in Israel, the data regarding his encounter, his visit, is broadcasted to Maccabi as a clinical data with all the recommendations given not as FHIR. It's sent as a simple XML file with all the details, some coded, some not coded, but we receive the data and we consider it part of our medical record. But the funny thing is that the same, maybe same, I'll put a question mark next to the word same, the same data is also broadcasted from hospitals to Maccabi from the financial aspect, because in Israel, the HMOs are the insuring body for the patients, and Maccabi has to pay the hospital for operations, for procedures that were performed on that patient if he's insured by Maccabi. So this hospital, except for sending clinical data, also sends a bill, and Maccabi gets that bill, and the bill includes diagnosis. So it's also another source that we need to look at and understand before we even start modeling to FHIR, just to understand the data. And let's start understanding the data. So if you look on our EMR, what is produced within Maccabi, we have around 55 million messages of diagnosis per year. And when I say messages, it can be a new diagnosis, it can be an updated diagnosis, or when diagnosis is erased or deleted, or active diagnosis, a constant one that's being stopped. It's also a message. The coding of those diagnoses is the local coding used within Maccabi. We call it Y codes. Those Y codes are mapped in a different system outside of the EMR to ICD-9, an older version of ICD-9. But we use Y codes and the description name, the diagnosis name, diagnosis description. Each diagnosis is also accompanied by a set of modifiers or characteristics. They can describe the body site where the diagnosis is. If it's a fracture, left leg, or they can indicate clinical status. If it's acute or chronic, or is it just a suspect or a status post? It can have several different modifiers, all coded in the same field, by the way. And as I said, and diagnosis can be deleted, can be updated. Confidentiality is not managed within the EMR itself per diagnosis. It's in a separate system. That's why it has a strike-through on them, because when we understood the data, we said, okay, we can't look at the confidentiality of this diagnosis from the diagnosis data itself. We need to process it with a different data source regarding the encounter. And something that was important later on when we decided when the FHIR modeling was performed. Looking at a second source of data, we talked about the financial one, the claims authorization or for the medication approvals. You can see the number of messages is much smaller because the majority or the vast majority of diagnosis of medications don't need specific approval, but still it's more than 1.5 million different messages, also coded in Y codes, our local coding, but we don't delete a message. When a diagnosis was given for the medication, it's there to stay. If the prescription will end, the patient doesn't need the medication anymore, Okay, we won't issue another message, but we won't delete the older ones. But they can be updated if the terms for a given medication is changed, or a diagnosis code is becoming obsolete and retired and replaced with a new one. So we do have an update. What about external sources? We talked about hospitals that we have clinical data, patients that are being discharged, and the data is sent to us. So we're talking about roughly 3.5 million yearly records. Here we start looking at seeing problems with the data, because sometimes the message includes a code, but the code can be ICD, only it can be of a local terminology from the organization itself, the hospital itself. They can include a description and code, or just a description, or both of them. And we had to regard it when talking about FHIR, because if we noticed that when data from hospital doesn't include the code sometimes, so we can't make it a mandatory field. We can't say, no, you don't have a code, I won't accept the data. I still need to accept it, and it's part of the FHIR modeling. Also, hospitals don't delete diagnosis they've sent. If they sent the data is in Maccabi. Even if they decide to change the EMR, the medical record on their side, they won't send, listen, delete that diagnosis, it's not correct. What they do sometimes is that they log a specific diagnosis, and then they decided to cancel it. And then we need to understand, do we look at it as a canceled diagnosis, as in something that was entered in error, because they found the hospital's EMR sent it to us. We need to understand how to use it. The last issue that I mentioned in the EMR wasn't logged. Here, confidentiality is a crucial part of the hospital data, because it transfers from one organization to the other. And if it was decided within the hospital that this log of a patient is confidential, either because it's psychiatric data, or if it's because a teen under 16 that undergone an abortion, and this is something that's by law in Israel is a confidential information, the diagnosis from the hospital will include a flag that says, listen, this is confidential, you can't share it with the entire organization. So this also has to be managed on the FHIR modeling level. How do we include it? Hospitals also send billing data. As I mentioned, we get the clinical, but we get also the billing because Maccabi has to pay. So here we have a bit less of 1 million messages. But it comes not only from hospitals, but also independent suppliers, let's say places that do X-ray for Maccabi insurees, and they send us the bill because the patient came to them. Also, they don't have a delete action. And here the coding is, excuse my French, a complete mess. Sometimes it's an ICD, an old ICD. For psychiatric data, it's ICD-10 because that's the standard in Israel. Sometimes it was ICD-9, but Israel decided to add local codes because they were missing from ICD-9. So we call it an ICD-9 modified IL coding. Sometimes it's a different system. If we read the data and see that it doesn't fall under the familiar ones, we simply don't give the coding a name, because we say we have the name of the diagnosis, we don't know how it's coded, we simply don't save any coding at all. And regarding modifiers, it has suspected for the billing because sometimes the procedure a specific procedure didn't happen because it's only a suspected diagnosis. It gets a bit more complicated, but our time is limited. I want to keep more time for the workshop itself. So what's I missed this, sorry. What's the overlap? I gave you different numbers. I said 3.5 million in our EMR. I said 1.5 million, 8,800. It changed. So this is a rough estimate of the overlap between the different sources, where the EMR covers almost everything that appears in the EMR appears, it's complete. But the financial side overlaps in about 30% to the EMR, although both of them are from Maccabi. Because not too many medications given in Maccabi require a supporting diagnosis. The clinical side of hospitals has about 30 to 50% overlap with the billing size of hospitals, because we don't always get a bill for everything, because some of the visits or encounters in the hospital are covered by the state or by privately funded insurance companies. So it's not everything that arrives to Maccabi. And there's some overlap between the hospitals and Maccabi itself. But it's not a complete overlap. And as I mentioned before, because the differences in the data itself, we need to understand how to represent cases when we have a diagnosis that appears in a few places, each of them with different data set. And one of the challenges was how to represent it in the FHIR modeling itself without confusing the consumers. So of course, when we started talking about FHIR, we're talking about the resource condition because that's what is being used for diagnosis. But the problem that risen due to all the things I said before is how do we do it correctly? How do we go through a FHIRizing procedure? And I call it FHIRizing because it's turning our data, different sources, different silos, different approaches to how to record diagnosis to FHIR, but we don't want to interfere the usage of the data and the process, and we want to keep it as similar as possible to the source system. We're talking about Maccabi's EMR and the way diagnoses are managed within the EMR. If tomorrow we're going to tell our business intelligence teams or analytics or anyone else here, you have the entire data modeled as FHIR, we want it to be as similar as possible logically to the EMR or to the hospital data to save time, to reduce the number of mistakes. And this is a question that goes throughout each of our FHIR projects, how we do it correctly. We don't interfere with the data flow and we don't interfere with the thinking. Even saying more, we want to use this opportunity to correct mistakes. We want to have better data structure and better usability, and thanks to that, better interoperability. So I have one small sample here to demonstrate, which I also talked about in the paper we wrote. And this is our modifier. As I said, we have a very long list of over 50, I think, if I remember correctly, different characteristics physician within Maccabi can attach to a diagnosis given during the encounter or for active diagnosis. If you look a bit about the list, you'll see it's a big mixture of body site or references like left or localized, and as I said before, clinical characteristics like chronic or acute. And am I sure of this diagnosis? Is it just a suspect? It's in Hebrew we call it mishmash because something of each place. If we look at FHIR and how the resource condition describes these characteristics, actually it has several relevant fields under the condition. Each of these fields, some of them are required and have a limited value set of values we can store inside. Some of them are very put whatever you want inside. And then we started looking at this list and tested if we can divide it to the FHIR recommended structure. And let's look for first thing about the red ones. All of the red ones that covered here are all FHIR recommended body sites. If it's location specific, if it's an axis or a or side, everything is fine. We can store inside. Similarly, the clinical status. I see that I had a problem here with the order of them. Never mind. I'll skip to the last one. All the light green ones are clinical status. All the dark green ones, you can see severity or verification status. And after a few days' work of a clinician working with a medical informatics specialist, we divided all of our modifiers to a correct FHIR status.
The project and Sophia.
Sorry? Excuse me? Okay. It takes time, it takes effort, and it takes multiple people who each of them knows something about either SNOMED or FHIR or the clinical side of the medical record itself within Maccabi to produce this list. But eventually, we took a mess, balagan, and made it into something which is in order, and something that if you want to question, to understand the data, and you look at this FHIR resource, you will understand better the diagnosis itself than the data that we had before. But this leads me to this point. FHIR does not stand alone. If we want to promote FHIR projects, we need to have also other things, or FHIR is a tool to help us better our mechanisms. First thing, we're talking about terminology. One of the biggest advantages of FHIR is that it enables us to use multiple terminologies for the same resource. The same diagnosis can be described with the local Y code and SNOMED CT. and if sometimes we'll move to a different terminology, it's a matter of running an update and we'll add a new terminology. And Maccabi is now working with organizations in Israel and under the support of the Ministry of Health that promotes a very wide terminology change or terminology shift in Israel to promote SNOMED CT, ICD from an updated version. And going on FHIR in Maccabi says also, let's move to a new terminology, to an international terminology, one that really enables interoperability without creating a new dictionary every single time, every single project. But it's not also only terminology. We're also talking about data quality. Once the data is modeled correctly, you can use it to enhance your capability to prevent mistakes. If you know, let's say we're talking about diagnosis, so let's give an example. On a normal day, we produce 5,000 diagnoses in Maccabi. For example, it's much more. Then if one day we have only 100, we need someone to see that red flag and say, here, we have a problem here. And once the data is organized correctly and documented correctly, and we know that FHIR has lots of add-ons and supported tools that can use the data structure, we can integrate data quality monitoring program within Maccabi to reduce mistakes and to, in general, upgrade all our data capabilities. So if to summarize, I know that there's lots more to talk about, and I'm sure we will talk about it later on today. First, a good FHIR implementation is the key to have a good outcome. If we didn't do the correct mapping in the beginning, both understand the business aspects, the data sources themselves, and starting to dig deep into the technical aspects of the different data sources, we couldn't arrive to a good outcome. We couldn't achieve this synergy between the different sources when we know exactly what each source contains or doesn't contain, and how to align them to the same standard that we aim to be at. And to achieve this, you have to have a resource I called it a resource to efforts balance, because we can't do everything. Of course, I would have hoped, I would have prayed to put on the table the entire data structure of Maccabi, all of the fields, encounters and diagnoses and allergies and referrals and lab results and imaging, and let's go FHIR on all of them till the end of 2023. But I know it's non-realistic. We can't focus all our efforts on all of the projects because we have a limitation of resource. But on the other hand, we don't want to focus all our efforts on one field, because if it will have some problem, some unexpected delay, some terminology issue that we don't know how to solve, then we lost time, we lost money, and we didn't promote our better medical record. So we need to balance, and Maccabi's choice was to go both on smaller projects and start with the bigger medical record FHIR representation, starting with diagnosis, but already during the development of the diagnosis use case, we started working on mapping the referrals, mapping the allergy intolerance, and we work in simultaneously on multiple projects, but from an understanding point that we have limited resources. And which resources I'm talking about? There are multiple resources. And you have to have, in my opinion, you have to have all of them working together, both the clinical side, the family physician, the expert physicians in specific fields that you're working on. You have to have medical informatics experts, and you have to have the digital teams, both the ones that know the organization's EMR and the organization legacy system, and also the FHIR team. You have to have someone who understands FHIR, who has a passion for FHIR, who wants to even improve FHIR models in the international level through the local use cases, because that's the way the FHIR community grew, and that's the way it will also work within the organization itself, but also in the national level. Because when you have such a multi-expert team inside the organization, they work together also with the national core profile team and promote a national standard. And that's the only way, as I said, in my opinion, to create a true interoperability within the health system, within the health ecosystem on the national level. So again, thank you for having me, and I'll conclude with this, and let us have a good workshop.
Thank you very much, Uri, for the insights. There we go. Very, very helpful and insightful to learn from your experience. And I'm sure there will be many questions in the workshop to further go into the details. But looking also at the time, without further ado, I already introduced Professor Sylvia Thun, who is the director at the core unit eHealth and Interoperability at the Berlin Institute of Health, who will give the second impulse. So, Frau Professor Thun, where are you? There we go. Without further ado, the floor is yours. Good to have you again here at the GIHF-AI.
Thank you, Carsten, and thank you, Uri. So I share my screen. Could you please give me the rights to share my screen? Thank you. Yeah, so my name is Sylvia Thun. I'm from Berlin, I'm from Charité, and I will talk about why we need FHIR to more use of artificial intelligence in medicine, and why do we need interoperability, and not only just FHIR, but much more like ontologies and DICOM and so on. So thank you for having me here, and I'm in this field since more than 20 years because as a young scientist and physician, I was convinced that we need digitalization, and therefore I worked a lot in the radiology field, and we finally won, and now radiology is very digital because of standards like DICOM and IHE. So today I will talk about HL7 and FHIR, and I myself, I'm the chair of HL7 Germany, and I'm deeply involved into the cooperation and collaboration at international level, at HL7 level, and there are several standardization organizations which I will show you later then. So I come from BIH at Charité, and Charité is one of the biggest university hospitals in Europe, and BIH, Berlin Institute of Health, is our research branch, which aims to translate findings from research into prediction, prevention, and therapy. So therefore, we need, and we have a very nice summit here next year, the World Health Summit, and I like to invite you all to our World Health Summit in 2023. So why do we need interoperability and fair data? Fair means findable, accessible, interoperable, and reusable. What are the benefits of interoperable data? So first of all, we can communicate with each other, doctor to doctor and doctor to patient, to avoid medical errors and reduce the documentation burden and empower our patients. So they should all have their EHR within their smartphone in the future. Then we can do research upon this data, but only if this data is fair enough for research and for AI, because if you have bad data or unstructured data, AI will be poor as well. So then we can provide algorithms which are trustworthy, and we can then do and have international cooperations that we needed very bad in the last pandemic. So 3 days ago, our Minister of Health provided us with the new German digitalization strategy, and I will show you some of interesting points here. First of all, he thinks we will have an EHR, and you see we don't have an EHR for patients right now, or just a few patients do have their EHRs in 24 and e-prescription services. So we can do these drugs interaction services as well, and give their give the data of the prescribed data and prescriptions and medication to all our citizens. Then our digital health agency will be owned by our federal government. It's not the case right now. And we will be not limited in our telemedicine service anymore. So everybody can do telemedicine and give telemedicine services, even not only physicians, but nurses as well. So there will be treatment programs, we call them disease management programs. Digital programs will be included into our EHR, and we will work together with our protection, our data protection, data security, data use and access committees very close together. So these are our new ideas. I think this is not so new for you in Israel, but one thing is quite interesting. It's the expansion of DIGA to medical devices of risk class 2B. We have like a law for digital applications, so our startups are able to make software and services and provide it to our patients, and they get paid by the insurance companies for their software. And then we do have so-called DIGA toolkits, and this is mainly FHIR, so that they can transfer data from the DIGA to the EHR. Yeah, this is what's new, and something that is not that new is our Interop Council for Digital Health in Germany. It's something like the ONC in the US. It's a national coordinator of health, where they built the United States core data set for interoperability, and we are on our way here as well. So we have core data sets for FHIR core data sets for Germany, and recommendations on standards, profiles, and guidelines. And behind our coordination office here are 160 experts who helps us for all the things that and the questions we have and hurdles of interoperability here in healthcare. So we provided a Interop Council roadmap for the next 2 years, and this is the basis for the Interoperability Council's work. It identifies and prioritizes appropriate actions to achieve the Council's long vision. And our long vision is shaping better medicine through greater interoperability and data-driven medicine. So what do? We talked about technology, services, and value set authorities, and we already used the ICD-10 and will use the ICD-11 very soon, and SNOMED, City, and Loing. We talked about nursing journeys and bridging the gap between outpatient care and hospital care. I was in the working group for the oncology journey right before this talk here. And yeah, you see many things to do, but we always include our physicians and patients in all these decisions. One decision was a very clear decision that all our specifications and our new specifications should be based on HL7 FHIR. That's quite easy, but if there are old specifications and we have some XML interfaces for reimbursement, quality assurance, and other applications like for our registries and cancer registries and proprietary XML, it's quite hard to map this to FHIR, because in FHIR things are very precise, and in the other applications things weren't as precise as we needed right now for FHIR. Yeah, but I think this was a very, very important decision, our jumpstart to FHIR. And the good thing is that we didn't have an EHR in Germany, so it's quite easy and very fast what we are doing right now. We don't have to map everything to FHIR because many things aren't there, and we can just specify the resources we need. Beside that, we are working quite hard on OrphaNet. This is for rare diseases. We implemented OrphaNet into our hospital information systems this year, and SNOMED and LOINC are important terminologies or ontologies in our medical information objects. IHE is testing the specifications worldwide and on a European level, and I think the next IHE connected Thun is in Germany, and I'd like to invite you. So who is responsible for all these standards? It's there are several standardization organizations, and I think you know more or less most of them, and I think HL7 is the most important standardization organization, but they are all under the roof of the Joint Initiative Council and the WHO, and the political aspect is here at the Global Digital Health Partnership level. And they have a new partnership with the Global Alliance for Genomics and Health. This is bioinformatics. And right now in Germany, we have huge programs which are going on genomics, Genom.de, and we try to align the standards of the HL7 standards and the bioinformatics standards. And there's one standard that is called phenopackets, and we try to implement this right now in Germany. So the first project of the Joint Initiative Council was the International Patient Summary. And this International Patient Summary was a European project, which was called EPSOS, European Patient Smart Open Services, in I think 2008 or something. And there we built the first EHR for European people. And then within a project that was called Trillium Bridge, we bridged it, mapped it to the specifications in the US. And then it was not only a CEN standard, but it became ISO standard. So everybody in the world could implement this standard. And this standard is based on SNOMED, ICD-10, and so on, ATC, and HL7 CDA. And now we try to map it to FHIR. And the new European law, the EHDS, European Health Data Space Law, points to the International Patient Summary in FHIR as well. So here are the objectives. We want to empower individuals, fostering a single market for digital health services, and have strict rules for research, innovation, policy making, and so on. So everybody in the EU should have an electronic health record, My Health at EU, and they can get their data with their apps. And this data can flow into several registries. And this empowers individuals, and it's for patient safety, continuity of care, and improve healthcare efficiency. And healthcare professionals have access to the data. Yeah, and so policymakers can make better decisions here if the data is available. So this is more or less the EHDS. So this is the way we are going here in Germany as well. And before that, we had the Medical Informatics Initiative. This is a huge project where 34 university hospitals work together to enable interoperability and to share data. And we made this first German core data set, and you see here basic modules. They are quite more or less quite easy, like procedures, lab results, like observations, medication, person, and encounter. And right now we are working on the extensions. We finished the genetic testing report, the pathology result report, and the imaging report, and try to implement it right now. And I think specifying things in FHIR is not that hard, but to implement it and to convince our industry is the hardest part here. So beside that, we built this German portal for medical research data, FDPG, and there you can see data which is available, and you can ask if you have a scientific question via a use and access committee, if you can get anonymized data out of this portal, and then you get research results. Here are some projects upon this platform, like the weather-based stroke event and outcome risk modeling, or we asked many questions about rare diseases, Kawasaki, PIMS, and so on. And as you all know, the rare diseases, which are 8,000, aren't included in the ICD-10. Just 300 rare diseases are included into the ICD-10. So we are right now try to use OfferNet. So, and biomarkers and so on and so on. And we can just ask all these questions we wanted to ask before the pandemic. And so it's a pity that we didn't have this system 2 years ago. So beside that, we built a so-called Corona consensus data set for the pandemic with 83 data items based on FHIR, and we used SNOMED, LOINC, and so our research community works within their clinical trials upon this metadata here, and so they can exchange data. And Orchestra is working with this GECKO data set as well, and Orchestra is an H2020 project from the EU. Besides that, we are trying to work with, we play, we like to play with the data from the Apple Watch and take it into our EHR and or from devices like Draga, and they have a new 11073 standard, which is called SDC, and we mapped it to HL7 FHIR, so we get data from the devices here as well. So beside that, we built this Vivantes Charité cooperation, and this is an example of a very successful implementation of FHIR in healthcare in Berlin. So we have here at Charité about 100 clinics and 4 sites, and in Berlin's largest maximum care provider, Vivantes, with 9 sites. We implemented an IHE document-based archive, so you can look at the documents. And beside that, right now, which is new, we have an interoperability platform for structured and granular based HL7 FHIR resources, so we can exchange data in Berlin. But you need many things for this, because it's not that easy, because it's not FHIR alone. You need to have processes which are interoperable. The organization should be more or less interoperable, and the terminologies should be used in both hospitals, with the same terminology. So that's quite hard. So this was our project last year, and we are not finished yet, but hopefully in a few months, we will have one platform in Berlin. The government will now give us the EHR 2.0, which is based on Smart on FHIR and FHIR. And within this EHR, we have several applications like the prenatal care pass, the vaccination, the pediatrician pass, and they will allow us to make telemonitoring or give us our lab data, because lab data is not available right now because labs don't use LOINC, and lab data is not at the insurance company level available because they only use ICDs and or procedure classification. So we don't really know which kind of lab data our citizens have. So my last slide for you, my takeaway message. Let's use FAIR principles so that we can use this data for scientific questions and have benefit from our digital data. And then we can use algorithms and so on. Yeah, thank you. This is my team, just a few of them.
Wonderful. Thank you so much, Sylvia Thun, for the input and the inspiring insights also into your work here in Berlin. I'm sure also here we will have several questions and remarks from the audience. So we are now switching to the interactive part after the first two impulses. We will have a mural board, so every one of you is invited to participate in this, and I'm handing over now to my dear colleague Lea Ledvon.